In this lesson, we're going to talk about acute kidney injury. Now, as you can guess, this is when we have a sudden onset of kidney damage and the kidneys get injured very acutely. So acute kidney injury is sudden loss of renal function, and it's generally caused by a perfusion issue or damage to the kidney tissue itself. You can see here on this kidney, this cross-section of a kidney, all the bleeding and swelling within the kidney that has been damaged. Now, you can imagine how hard it would be for the kidney to function and to do its normal job with this kind of damage. Now, it's usually reversible on its own within like about 1 to 2 weeks. Now, it also can be prevented. So think about that when we start talking about the causes here in just a minute. So if we aren't able to reverse it, or it doesn't reverse quickly on its own, it can lead to permanent damage and cause the patient what's called chronic kidney disease, or CKD, which is what we're going to talk about in the next module. There's 3 categories of causes of acute kidney injury, and they have to do with the source of the problem. Now, those are prerenal, intrarenal, and postrenal. So prerenal means before the kidney. So the source of the problem is what comes before the kidney. Now, which means the blood flow into the kidneys themselves. Okay. Now, if blood isn't flowing into the kidneys, not only do they not get perfused and can occur some ischemic damage, but they also can't filter blood if it's not there. Now, some causes of prerenal kidney injury would be like hypotension, hypovolemia, or any decrease in cardiac output. So you would see like things like heart failure or shock. So things that are kind of decreasing our blood volume into our kidneys, which is then going to cause that prerenal damage. Now, intrarenal means that the source of the problem is coming from within the kidneys themselves. So blood flow is fine, but there's been damage to the kidney tissue or cells that's making it not work correctly. So here's our problem right here. Now, common causes of intrarenal kidney injury are things like infection, tubular necrosis, nephrotoxic drugs. And that's why we need to be really careful with medications we give our patients, or contrast dye. Now, you've probably already seen this a lot, different questions and different patients with contrast dye. So the contrast dye is super concentrated, and it's sometimes really hard for the kidneys to actually filter out. Now, that's why you'll see us give patients extra fluids before they have a contrast scan, and that's really to help protect the kidneys. All right. Now, finally, we have post-renal kidney injury. Now, as you can guess, this is caused by something happening after the kidneys. Now, what usually happens is there's some sort of infection or obstruction, like a stone that causes backflow into the kidneys. All right. Now, the kidneys fill with fluid because it can't get out. So we aren't able to get this fluid all out, and the kidneys start to fill up with fluid. But the problem is something after the kidneys. Now, that's called hydronephrosis, when the kidneys begin to fill with this fluid. And it causes damage and decreased kidney function. So ultimately, prerenal and postrenal sources cause damage to the kidney itself, but we name this because the original source of the problem is either before or after the kidney. Now, we need to make sure we keep the patient's blood pressure up. We need to make sure we keep them well hydrated. And we need to protect their kidneys from injury with drugs and contrast and things like that. Now, we need to treat infections and remove obstructions as quickly as possible. All right. Acute kidney injury really comes in, or it goes through 4 different phases. Now, you really want to try to catch this as early as you can to help prevent as much damage and prevent them progressing as much as we can. In onset, what happens is we start seeing a decline in their baseline urine output. Now take note of that I said baseline. We'll talk about that in a second. Well, we all know that baseline or minimum urine output that we want to see in our patient is 30 mils per hour, right? So that comes out to about 720 mils per day of urine output. Now what will happen is our patient will be cruising along at about 1,200 mils per day, and everything's fine, right? Because that's about 50 mils per hour. Now what you'll notice is the patient then suddenly goes down to 30 mils an hour. And you might think to yourself, that's fine, no worries, they're still above the minimum. But if we look at that, their baseline, their norm for this patient was 50 mils an hour. They just dropped down 20 mils an hour, right? So their daily output has gone down by nearly 500 mils for this patient. Now you got to notice these things. What really matters in our patients is trends. That's why you need to be charting your vitals and paying attention to your vitals as you go along so you can really watch what's happening in your patient. This patient here, even though they're at the baseline, the norm here that we want, the minimum, they have dropped 500 mils per day of urine output. That's a lot. So that's onset there, as we'll see this kind of decrease in normal output. But as they continue along and continue to get worse, they'll drop into what's known as the oliguric phase. This is the acute, sick phase of acute kidney injury. We'll see their urine output drop to less than 400 mils per day. So that's like 16 mils an hour. Hardly anything, just barely anything. And what urine they do produce will be super concentrated and dark, almost like this over here. Now it almost looked like tea, or like a really dark tea. Now, their BUN and their creatinine will start to go up because the kidneys aren't doing their job. So BUN, creatinine start to climb, and we're going to see our GFR, which is glomerular filtration rate, start to drop because the kidneys aren't filtering the blood as fast as they should. Now, it's during this phase we're going to see all the symptoms of kidney failure that we'll talk about in just a second. BUN and creatinine are going up, urine output's dropping drastically, and GFR is going down. Now, as the kidneys begin to recover, they enter into what's called the diuretic phase. So what we're going to see is we're going to see their urine output slowly start to increase, and then suddenly they're going to start diuresing just like crazy. They're going to start having a ton of urine output. Basically, what's happening is the kidneys are now working, and they're trying to get rid of all this extra fluid that they haven't been able to get rid of, that they've been holding on to. So then we'll get into this recovery phase. After they get rid of all that fluid, we'll start to see our GFR normalize, and slowly but surely everything gets back to normal. Urine output gets back to where it should be. BUN and creatinine normalize, GFR normalizes, and the patient starts to look good again. So let's talk about the symptoms you're going to see specifically during our oliguric phase. Okay, this is the sick phase of this. Well, all the symptoms are based on the fact that the kidneys are unable to perform their functions. So we talk about those in detail in the module intro. So we're going to see what's called azotemia, which is really a buildup of nitrogenous waste products. Okay, that's azotemia. So when you see that, think nitrogenous waste products, since they can't filter all these things out. Now that's when we see things like BUN and creatinine start to climb. But we also start to see GFR drop. Now, I really want you guys to focus on GFR, or glomerular filtration rate. All right, because a lot of times we don't talk about it, we don't give it enough credit. Because if you ask people, like, what labs would you check for renal function, a lot of people would say BUN and creatinine. Now, there's one problem with that. The BUN and creatinine can be elevated in other things like muscle damage. It can even be affected with the liver. It can be affected with dehydration, but GFR, or glomerular filtration rate, literally measures the amount of volume the glomerulus, which is in the kidneys, can filter in any given minute. Okay, this is really like a fluid per minute measure that the kidneys can filter in any given minute. It's very specific to the kidneys, and it's highly reflective of renal function, so don't discount it. Now, that being said, we already talked about seeing a decrease in urine output and how concentrated it would be. Since they aren't able to get the fluid out, we actually start to see signs of volume overload in their system. They're holding on to all this fluid because the kidneys aren't working, so we start seeing things like volume overload. So we'd hear like crackles, and we might see this type of pitting edema in our patient as well, peripheral edema. And as it progresses, we might also see pulmonary edema as well. So they would also be like shortness of breath and the crackles that we talked about as this fluid starts to build up. Now, because the kidneys aren't retaining the bicarb buffer like they should, we're going to start seeing metabolic acidosis. Now, what's metabolic acidosis going to look like? That's going to be a pH of less than 7.35 and a bicarb less than 22. Okay, low pH, low bicarb. And we know that non-functioning kidneys can't regulate electrolytes like they should. So we want to look more closely at this during our chronic kidney disease lecture, our CKD lecture. But what we'll see is we're going to see an increase in potassium, a decrease in sodium, an increase in phosphate, and a decrease in calcium. And then, of course, if infection was the source, we're going to start seeing all our signs and symptoms of infection. Increased heart rate, we might see increased temp, increased WBCs. So what is the therapeutic management? What are we going to do for this patient? Well, during the oliguric phase, we actually want to restrict fluids just a little bit, all right? The last thing we need is to overload them even more than they already are, since they're not able to filter this fluid. We want to try to identify and treat the cause, and we'll give diuretics to try to get the fluid out of their system. Now, once they hit the diuretic phase, we want to make sure we balance their fluid status and replace any electrolytes as needed. We especially want to watch potassium and sodium because those can be life-threatening if they're outside their normal range, even by just a little bit. So if the patients don't seem to be getting better or aren't responding to treatment, we may need to start them on hemodialysis. Now, we'll talk about that more during our hemodialysis, during the CKD lecture, but just be aware that if we can't get this fluid off, we can't regulate these electrolytes, we will need to look at dialysis for our patient. So our priority nursing concepts for acute kidney injury are going to be fluid electrolyte, elimination, and perfusion. Now, because we want to make sure that their kidneys are getting blood flow that they need. Now, make sure you check out the care plan and all the other resources attached to this lesson to help you kind of understand what we're doing for these patients. All right, let's recap. Acute kidney injury is a sudden but usually reversible damage to the kidney. Okay, now if it's caught early enough, we can usually reverse it very quickly. Now, we want to identify and treat the cause, whether it's pre-renal, meaning it happens before the kidneys, whether it's pre-renal, intrarenal, or a post-renal issue. We want to identify and treat that cause as much as we can to help prevent permanent damage. Now, we're going to see signs and symptoms of volume overload and electrolyte abnormalities, and we especially want to watch out for hyperkalemia. Now, we're also going to see things like azotemia. We're going to see metabolic acidosis, because the kidneys just aren't able to do their jobs. We want to support kidney function. We might do that by giving things like diuretics and fluids, but the patient may also require dialysis. Okay, and keep that in mind if the patient isn't recovering as they need to be. All right, guys, that's acute kidney injury. I really want you to focus on the phases, and I want you to focus on the trends and the labs that you're going to see and how you're going to treat the patient based on those things. All right, guys, I want you to go out and be your best self today. And as always, happy nursing.